Welcome to this first meetup, Brocher, Fondation Brocher. Today I'm going to facilitate the first half of this session, and Ciara Staunton is going to facilitate the Q&A session. So we are very fortunate to have Dr. Joanne Liu calling us from Canada, from Quebec, and who used to be the president of MSF International, Médecins Sans Frontières International, and is currently involved in the independent evaluation of the COVID response of WHO. And Professor Antoine Flahault, who is the director of the Institute for Global Health at University of Geneva, and myself, the director of the Geneva Center of Humanitarian Studies. So the three of us have been involved more or less in some of the latest epidemics and the COVID-19 pandemic, and I think it would be nice to hear from us what has been what we have learned and some of the reflections we can have for the present and for the near future. As an introduction, I would like to talk about some of the work we've been doing at the Geneva Center of Humanitarian Studies, looking at how the COVID-19 response has been implemented in humanitarian settings, in armed conflicts, and we have actually created the COVID-19 Humanitarian Platform, which is an initiative from the London School of Hygiene and Tropical Medicine, the Johns Hopkins School of Public Health, and ourselves, to try to collect all the latest evidence on COVID-19 response and humanitarian settings, but as well to provide some guidance that is more contextually adapted. And I think some of the key aspects we have learned from the past epidemics and outbreaks is very much about some of the need to adapt to context. So we can talk about that, Joanne, and because you've been highly involved in the previous not pandemic, epidemics in West Africa and in Congo, Kinshasa. And one of the key questions we have always is about, can we learn from these past epidemics? What are the limitations in a way to learn from these past epidemics? But as well to try to understand what could be actually duplicated. And I'm thinking here about some of the key highlight messages we had from Ebola, which was very much about community engagement, the need to have a more systemic approach to outbreaks, moving away from a simple clinical approach. And it looks like, if we look at the response in Europe, in the US, in North America, and some of the other countries, I don't have the feeling we have learned a lot from that. What do you think?
Good morning, good afternoon, good evening, everybody. And it is my distinguished pleasure to be with you today, early on in Canada. So I think that with respect, what we learned from past epidemic and regional epidemic, if to say it shortly, I think that we are slow learner. That would be like the most politically correct thing to say. But the reality is, if we track back to Ebola 2014, 2016, I think that what the legacy of that is the fact that for once in the, I would say, contemporary history of humankind, we had a phase to what could be a bio threat at large scale. And all of a sudden people just say, oh, this is how it can look like. So that was one thing. And then at macro level, I think what we learn is the fact that there's massive, medical, social, and economic impacts. We learned that we should be able to put, and have some solidarity mechanisms. We should create some common goods. And in that respect, a lot of people were saying research, but knowledge. But even more than that was whatever we develop in terms of R&D, research and development, like vaccine or therapeutic or diagnostic, should become a public good. And then the other thing that we learn is the fact that it's one thing to care for the people who are affected, which is key. But we need as well to make sure that there's not what we call the indirect impact of an epidemic, which is all in that time, the non-Ebola care. And then most likely the studies that we have today probably show that there were as much, if not more, people impacted negatively medically about Ebola. And we probably will find the same thing for COVID-19. So these are the thing we learn. And then the other thing is the fact is things that we sort of said that we should not go there, like quarantine or travel ban. It's actually exactly what we've done the opposite way, 180 degrees for COVID-19. So I think it's hard to do a cut and paste of what we should have learned. And in addition to that, I think one of the glaring, blatant blind spot that we had, because we just said after that, never again, we're going to create mechanism like the international health regulation, we're going to implement it, we're going to have like all sort of different things to do. And what we realize is that everything that we thought could prepare us the most actually did not really. And if you look at the epidemic preparedness index, the countries who were the highest ranked, like the US, have done the most poorly. So we definitely don't have the right metrics to find out how prepared we are. That's for sure. So in all this, it's really interesting to see that we cannot do a cut and paste of what happened. On the other hand, there are what I call pattern in epidemic that become pandemic, and then one of the pattern is like fear is big. Fear is something that we need to manage and control, and if it's not, then it leads to all sort of complotisms and too much imagination. And then the other thing is the fact that if we don't control fear, then we're not able to get the buy-in of people in terms of combating the epidemic. And I always say, and this is one of the key lessons learned that we have from Ebola, but from cholera before, is every single epidemic starts and stops in the community. So the role of the community is key. And if we don't get them on board, you may have as much top-down as you want, as much regulation and policy. You will face, like we're facing, a second peak and probably a third peak and a fourth peak. And in addition to that, there's going to be this whole thing about vaccine hesitancy, and this is going to be difficult. So we are in a difficult moment with respect to that. I don't think we've learned everything that we should have learned. And I think we should be humble about the fact that we are still learning. So I'll stop there.
Yeah, thank you very much. And I do think these are very important aspects. One of the key. I'm very surprised when I looked at the COVID-19 response, how much it depends on collective behavior, and it seems that we are failing on that. I mean, many countries. I mean, the second wave in many countries like Switzerland and France seems to be very, very strong. And so my question is to Antoine now, is to have a sense of how on earth, how do we have a second wave? So the season can be explained, the winter can be one factor explaining that the second wave in some of the countries where we live, Switzerland is one of them, France is the second one. The second wave seems to be stronger and much higher, much more intense in terms of infections. I'm not talking about hospitalization, but and so these are questions related to collective behavior. Joanne talked about fear, talked about trust as well, and we had some discussions with a few colleagues this week about how to restore trust in health services and hospitals and facilities in some of the countries. So we've got some concerns on how to restore that. And it looks like to me, and Antoine, you're a member of a few scientific committees and you've been involved in some of the decisions or advising on some of the decisions, is where is social science as well in this environment? If you can give a sense of, one, the second wave, what is your feeling about that? And the second one is, do you have many social scientists around you who can advise governments?
Yeah, thank you, Karl and Joanne for this conversation, and at the fabulous location of the Brocher Fondation, which is now online, but as fabulous as usual. Yes, I think, in March, we received a couple of cases from China, maybe from Italy at the early beginning, but I meant that we did not have, the seed was a very small number of cases. So the reproductive rate at that time was much higher, which about 3 in Europe. And when you have even a reproductive rate which is high, when you start from very small numbers, it takes time to grow. Of course, it's an exponential growth, so it ends to make an epidemic. But that was in March, so in May, that was the summertime, and there was a break, I would say, partly due to the summertime. The seasonal break is not a blockage. It's not something which blocked completely the epidemic, and the USA, for instance, had to experience some outbreaks because probably they did not associate to this summer break any measures which were effective enough, such as the mask wearing in public transportation, which was mandatory in most countries in Europe, and even some physical distance and other hygiene measures. In Europe, we did it, in Canada also, and we succeeded to have something which was more relaxed during the summer. But in this summertime, the circulation of the virus in Europe, in the Canada, was quite important. I mean, there was a huge amount of PCR positive which were found in summertime, in August, in September. And so when we started again, that was not true for the Asian countries, and we can come back on that. Maybe that will be also a comment for the second part of your question. But when we came in the end of September, we had not a couple of cases coming from China or from Italy or from Iran. We had thousands of cases which fueled an outbreak with a reproductive rate which was at least halved from that one from March, but of course, which was much above 1 and which probably around 1.5, and which allowed the epidemic to start with an exponential phase. We just have to realize that 1.5 seems not a lot, but it is exactly the R0 of influenza. So you make a splendid, if you allow me this term, outbreak of influenza with 1.5, and you make a pandemic flu with 1.5. So we had 1.5. Why? Much because this seasonal break had disappeared. We came back to work. When I say seasonal break, I'm not saying only temperature and humidity. I'm saying all our behaviors. In summer times, we open the windows. In summer times, we are outdoors mainly. We are exactly not in the place where we experience super spreading events. So, of course, coming back in these auditoriums, in these restaurants, indoors, coming back in fitness centers and not jogging along the rivers and the lake, we had to experience this epidemic. That is my hypothesis to explain these different waves. And as you said, the second wave is clearly higher than the first one. And to go just to the second part of your questions, what I can say, but I don't know if you would agree on that, is that it seems to me that there is not a universal ethics. I mean that some ethics concepts are not completely shared between many Asian countries, and I'm not talking about the authoritarian communism in China, I'm talking about the democracy in Asia, like in Japan, like in South Korea, like in Taiwan, like in Hong Kong, or even in Singapore, which is a bit more authoritarian. But they do not share the same ethics in many aspects of this pandemic. And I could not say they are wrong. I will finish after that, but just one example, which is for me striking, is about the usage of artificial intelligence and apps. You know, all these digital traces we have currently. For us in Europe, and I assume that it is similar in Americas, but maybe Joanne, you will comment on that. But for us in Europe, we have in French, it is named Règlement Général de Protection des Données. So it's the general rules for data protection. It's a European, EU regulation which applies even in Switzerland. We have signed it. And it is a philosophy that our digital traces are very confidential, very well protected, and above all, most of all, the freedom, the restriction of freedom we are keen to share. In Asia, they are much more intrusive, even in very democratic countries. They use our trace mandatory. I mean, we do not have an opt-in or even an opt-out component in this usage of the traces by the health authorities, only for the pandemic purpose, they say. They use our credit cards. They use video surveillance camera in the streets, in the public areas. And with that, they were very, very effective in looking for contacts, in contact tracing. So they organize what they called a backward contact tracing approach, which was highly successful because they were helped by these traces. And we say it's not possible in Europe. And what did they answer? What did they question to us is why? You feel we are very intrusive with our digital traces, but our digital traces only lock down those who are infected. That's the reason why. So we only lock down those who are infected, isolate them from the well-being, the people without infection. When in Europe, you restrict people to go outside of their own home. It's not something which is against freedom. So you are very, so just to say, for me, it's a different approach of ethics and probably law with regard with freedom in both parts of democratic countries in the world.
Yeah, so that's very interesting because I think then I will leave the floor to Ciara and the questions from the audience. But I do think that this suddenly I realized being a public health specialist, I'm dealing with this notion of freedom, this notion of responsibility, and it makes us rethink a bit more about all these notions and how compatible some of the public health response can be aligned with individual and collective freedom, personal or collective responsibility. So that's very interesting. I think it's interesting how much some people feared or felt completely threatened by these apps and these Stop COVID apps and so on. It's very, very interesting. And there's a huge controversy. Ciara, do you want to?
Yeah, so a couple of alumni in advance of this submitted questions, and unsurprisingly, considering the development this week, vaccines featured very heavily. And I see here from the questions that questions around vaccines have already been merged. But I suppose the main issue that was asked is around equity and allocation of the vaccines. And I think two elements have been identified in the questions. One is, how do we ensure fair allocation of vaccines across the world? And I think an interesting point came from Arthur Kaplan when he asked about how do we ensure equitable allocation, considering that some countries may actually be investing more heavy into the development of these vaccines. Should they get preferential access, or how should it actually be accommodated?
Joanne, you want to start?
Yeah, that's the hot potato question of the week. In that respect, I think that I don't think we're going to be able to answer that with COVID-19 in this episode. What is clear of what has been done so far is that we've created platform that one is called COVAX, and basically it's a platform that countries bet some money and then they say, well, we're going to put basically a pot together and we're going to redistribute the vaccine. That platform has negotiated pre-order. They didn't do pre-order, but they has negotiated with some industry to have access to vaccine. The issue about that is the idea is not bad to a certain extent, but we all know that several rich nations have done bilateral deal upstream pre-order of vaccine with different company. And so that most likely what will happen is the industry will basically honor the bilateral deal that they have done. And then afterwards, whatever is going to be left over, they're going to put it in this platform, and then they're going to redistribute it. So I think it's very, very unlikely that we're going to have an equitable for this time around. I think we should start to think about the future in a much more responsible way and much more sustainable way. And I think for me, what I would like to see is the fact that we like it's been done, a few weeks ago, is to allow a waiver on intellectual property. And this is what India and South Africa has been asking. It's a waiver on intellectual property on products related to COVID-19, which allow those countries afterwards to be able to manufacture. And I think that if we are looking for what I call a sustainable manufacture, because most likely countries will never be able to make low and middle income country are unlikely to be able to make deal with the industry upstream and have I would say pre-order number of vaccine. But if we foster for them for next time around to be able to manufacture it, then they may have be a little bit more, I would say, autonomous, and then we'll have a little bit more control on protecting their community. So I doubt that we're going to have. I think there's going to be an effort to try to redistribute, but we cannot be. I would say, oblivious to the fact that there were massive bilateral deals between rich nation and industry, and this will have precedent in terms of reallocating or distributing the vaccine.
Karl, if I may add, I think the question about equity between countries, and Joanne has clearly described the issue we have. I do think that there's no international regulation to force countries to keep a portion of the vaccine for other countries. So that's not going to happen now. The second issue is going to be about equity within countries. And here, I do think that we need to prioritize healthcare workers and patients with comorbidities and elderly people. They need to be the first one to benefit from the vaccines. But when we have resolved this ethical issue about who should get the vaccine first, there will be other issues. I think if we do this first line of population, vulnerable groups who need to get access to vaccines, I'm not sure we're going to have vaccines available, but I'm not sure we're going to have people interested to be vaccinated. There's such a high level of hesitancy and mistrust in vaccines today. In Europe, in some of the countries like France, I mean, the latest poll on vaccine, 54% of the French population is not going to trust the new vaccine. How are we going to be able to develop a campaign to inform people about the safety of the vaccine and make sure they get access to, they go and get vaccinated? I'm not sure that's going to be another issue for us. And the third one is going to be about logistics. When you talk about a vaccine that needs to be kept under 80 degrees, how are we going to do it in some of the countries? We know that the invoice for the US is going to be already very high. So think about some of the countries in Sub-Saharan Africa, how they're going to manage these extra cost for the health system.
I don't know if I can add very few comments on the top of yours. I would say I'm confident for a couple of reasons that we may have vaccines for all. Of course, as Karl mentioned, for all who want them, and it's not for granted. But first of all, there is today still 150 candidate vaccines racing to be approved. So it may appear that we have more than one vaccine at the end of the day, and maybe a couple of them from different regions. And it may appear also that thanks to that, we can provide access to many of the human beings for these vaccines. The second element of hope is the fact that we have already succeeded to do that for a couple of diseases. For instance, for smallpox, we have succeeded to eradicate smallpox thanks to the coordination of WHO, which was not stronger than it is now, and it was not a much better time when it occurs, because it was during the Cold War. It was not, again, for granted that there will be a strong collaboration between Russia, the former USSR, the USA and the Western Bloc, and China, and it happens successfully. And for poliomyelitis, much more recently, we are currently providing vaccines for all, and the most difficult issue is more vaccine hesitancy, as you mentioned, Karl, which is not only a matter of developed and rich countries, but which occur also in many poor countries. So this is a real issue, as you say. And the last point is, in fact, I don't consider that there is one COVID disease. There is 3 COVID diseases at least. One is when you are below 40 or 50, you experience a very mild disease. I'm not talking about long COVID, which is not very clear today, but about mortality and severity. You will not be hospitalized, almost certainly, if you experience a COVID below 50. And above, it becomes such a severe disease that between 50 and 70, it's as dangerous as SARS was, with 10% mortality rates very frequently observed in this age zone. And above 70, it becomes like Ebola in Africa. I think it's a very dangerous disease with 25, 30, sometimes 50% of mortality if you accumulate comorbidities. So we can imagine that for almost half of our societies, which the median age in Switzerland is 42 years, so half of the population will never experience a very severe disease due to COVID, or almost never, I should say. And we can understand, I'm not saying that we can justify, but we can understand this hesitancy among these people, the young segment of the population, which do not fear anything for them. They do not want to transmit to the elderly. But if there is a vaccine for the elderly, now maybe I may not want to experience a vaccine which is unknown for its long-term effects, and I don't know what will be the result. So in a way, we can have some understanding for this young segment of the population. The very big issue for me will be about the healthcare workers and those who are in charge of the nursing home, because that should be mandatory for them, and that will be probably, because we don't want them to spill over their virus to their patients or to the elderly they are in care of. And so that may be an issue for them, because they may not want to be voluntary for being vaccinated. Over from.
Can I react to some of what was said? I just wanted to say that in terms of, I agree that there is sort of three COVID disease in terms of CFR, case fatality rate, but I think that in terms of symptoms and sequela, we realize that the young do have sequela, and some early study in Canada are showing that about a third will have midterm to long-term sequela. So this is not yet, hard evidence, but is observational so far. But so there is this that I think that we have to keep in mind, that it's not as easy as this. And I just wanted to react as well to your summer break, or your Antoine, which I think that I think it was like, because it was summer, but I think why we had possibly a second peak is that we end up, because we have a relaxed lockdown, we end up having a lot of silent community transmission. And this is what basically has contributed to what we see now in fall time. And I just see the comment on people about the vaccine, and then the logistic of the cold chain. And I think the cold chain is a real issue. I think that, yes, we manage in DRC. I work in DRC for Ebola. We have to keep in mind that the world was supporting DRC to vaccinate the population. I'm saying that because there was like a huge focus from WHO, the World Bank, many NGOs were there, and we massively invested to make this happen. Thing that we will probably not be able to do in dozens of countries at the same time. So this is why I'm quite concerned that if we have a cold chain that is as low as this, is going to be very, very challenging.
Mm.
Just one point regarding the cold chain. There are two categories of vaccines. I mean, the inactivated vaccines and the spike protein vaccines, which will not require this cold chain. So fortunately, if we are fortunate enough to have these vaccines approved also, that may solve part of the problem.
Yeah. And to talk about vaccinations, Ciara, if you don't mind. So we talk about the COVID-19 vaccination. And when I was listening to Joanne, and then I'm thinking about all the interruption of immunization programs in many countries. It made me think as well, we're going to have the new vaccination campaign happening in a few months, hopefully next year. But today we already have a lot of interruption in vaccination programs in many countries. So it made me think about what Antoine was just talking about when we talk about COVID-19 related death and morbidity. We also have a lot of excess mortality and morbidity, not due to COVID, due to the fact that a lot of services have been interrupted or delayed. And talking about non-communicable diseases, there's strong evidence now on oncology and so on, a lot of and mental health. A lot of services have been interrupted or postponed, and these are going to have long-term implications on populations and on patients.
So if we want to shift away, I suppose, from vaccines to kind of more preventative measures, you could arguably call this COVID-19 our first sort of digital pandemic, when there's an awful lot of reliance on digital tools as preventive measures. We've seen a huge amount of ethical reflection in the literature on the ethics around surveillance app, contact tracing apps. And unsurprisingly, some of the questions we've received, and also the chat here, is about how to balance autonomy with more collective interests. But what have we learned Joanne, would you have thought from previous epidemics and how to balance these kind of more personal autonomy-related issues with more collective interest in protecting others? And also, how has this been played out, I suppose, Antoine, you may have reflections on, across the world in different contexts? How do we balance this, this tension that there is between collective and more individual rights and interests?
Right. It's this is more, I would say, at the level of a personal observation, but that has gained more and more ground, as we went along, especially in West Africa and after that in Yemen. But it's like what I said before. People will be ready and willing to look at it and from a collective perspective when they will understand and then will own the epidemic, and then they will feel that they are part of the solution. And I think what we failed to do in COVID-19 is the fact that it was anyway, I'm talking about, I've seen more what happened in Canada, but in many countries seems to be, I think there was a lot of top-down, I would say, guidance from the public health, and if you were like not complying to that, you were demonized, and there was very little, I would say, room for a local, I would say, initiative to try to find their own response. And I'm talking about that, and the example that we gave is in West Africa, in Liberia. There were a village in Foya, and we've been trying to get people to be compliant and come to the Ebola Center and everything. And once we were more taking time to talk to people and then sat and asked them, what would be, things that are acceptable for you, what they were understanding and spending time with them. And the main thing was about, I remember it was about having dignified and safe funerals. The whole thing about funerals was a huge thing. And once we understood that, and we just said, okay, you need to bury your people, we need to adapt, we need to adapt ourselves to this, and then we make it happen instead of banning it. And then once we were respecting the community, they changed their behavior. They did themselves their own self-isolation. And then actually the number of cases in Liberia started to decrease before the big international deployment of the 3,000 GI from the US. And you can look at the graph in Liberia. So the thing is, community needs to own the epidemic, needs to understand, and then needs to be part of the solution instead of being treated as if they are part of the disruption of the response. Yeah. And then we have failed to make community owning the epidemic so far.
Well, Joanne, there are a few, I completely agree with you, but I think there are a lot of explanations why we have failed at a very early stage, in a sense that we were all discovering a new disease and trying to understand it. So we were completely unable as scientists to give clear evidence of what the disease is about and clear messages to the public. And you could see on TV quite a few scientists actually challenging each other. And so I think for giving an image of science like that didn't help to bring some trust among the public. I think it's very clear. Nowadays, I think we have a better understanding. We have stronger data and stronger evidence. I think you're absolutely right. Now it's time to give to the public a clear understanding of what they can do at their own level, what the disease is about, and understand the measures governments are going to take. I think that's very important. It made me think as well about what you just said about the local response and international guidance. And I've got a clear example here where we have a lot of guidance that have been developed for high-income countries, because this is where the epicenter is. And suddenly humanitarian organizations were within a gap of knowledge, because all these international guidelines from WHO and CDC and others were absolutely not adapted to their context. So what they did, as you just said, some of the communities started to implement measures, and others started to innovate and to be productive and to test and to be very much contextually adapted. And that's very, very, very interesting to see that. I completely agree with you about the role of communities. How to do it is still a key question for all the scientists in the world. Making sure that the public is going to be behind, is going to accept the measures. You look at all the scientific committees in many countries. There's no single voice for patient associations. They're not there. They're not around the table. You only have scientists. You only have most of the time clinicians. And so I think you're probably right. There's a time we change the way we communicate and dialogue with communities.
But if I may say, just, and then I'll let you after, Antoine, we see a lot of things about people and their behavior. On the other hand, there is nothing recent where we ask so much on people in terms of restraining their freedom and policing their behavior. Mm-hmm. So I think that we have to acknowledge that this is like a first for so many decades, and therefore I'm not surprised in that respect. And I think that one of the things we learned from Ebola as well is encouragement message from the authorities is really conducive for non-compliance to any of the rules. And this is what happened initially. And I think what we miss is having a clear communication saying, this is what we know, this is what we don't know, and this is what we would like to know. And if we would have had straight from the beginning, I think that we would have get probably more people on board. So sorry, Antoine, go ahead.
Thank you. Hey, Antoine, I'm just looking at the time. So I give you the floor and I let you conclude this meetup.
Okay, we have one quarter more, no?
1 minute, I think, 2 minutes.
Oh, it was okay. So we have to finish. No, I was just slightly in disagreement with what has been said. I think really when you see the Irish case in Ireland, in Ireland, the authorities declared the lockdown on the 21st of October. The 23rd of October, 2 days after, the curve was cut and it was slowing down in 2 days. That means it's not because of the top-down decision from the politicians that it happens. It is because of a bottom-up self-lockdown, if I may call it, that it happens. And in fact, the communities take the floors much before the politicians. It's a kind of game in democracies to think that the politicians steer and manage the crisis. In fact, when the people perceive the risk enough, they take their own decisions collectively or by their own, and it has been proven. What I'm saying has been documented. The Google Mobility, you can go, it's open source. You can go and visit them. These mobility data show a dramatic decrease in mobility in Ireland, and it is the same also in Canada. It is the same in France, much before the decisions were taken. So, to me, there is not so conflicting between the top-down and bottom-up, and probably the bottom-up precede the top-down decisions. Over from me, and thank you very much for that.
So I think we have to conclude here because we just over 1 minute. I think I leave the floor to you, Antoine, to announce.
Okay, so it's not a conclusion. It's just to invite all of you. You appreciate this meetup Brocher meeting. You will most probably appreciate the next one, which will be done by one of our participants. He asked questions. It's Arthur Captain. He will organize also on COVID-19, the 28th of January at the same time, 1:30 Geneva time, a meetup meeting. So don't miss it. It is for you if you are among the alumni of the Brocher Foundation or if you are just participants who love the Brocher Foundation as we do.
Thank you very much. Thank you very much, everybody, and thank you for the Fondation. Thank you, Ciara. Thank you, Joanne, and thank you, Antoine, for this first meetup. And see you soon for the second one in January. Thank you very much.
Thank you.
Thank you. Bye-bye, Joanne.
Bye.
Thank you, Karl. Thank you, Ciara. And thank you, all Annick Girard and Cécile Caldwell, all the staff at the Brocher Foundation. Bye.
Bye-bye.